Go live.
Yep. And there's a lag with this one.
Excuse me.
All right.
Was that?
You're live.
I'm live? Okay. Hey, this is Elliot Fishman. And, oh, here I am with the mask. I guess it's delayed. But this is our CTisus December quiz. This is the live quiz. I have 10 great cases for you. This is our last CTisus YouTube quiz for the year, I think, unless I come up with something else. But remember, we do it once a month, and here we go. We'll see how well you do. 10 terrific cases. So on this first case, patient presents middle-aged female with abdominal distension. When you look at the images, you see extensive ascites, and then you look and you see bilateral pelvic masses. These masses are large. They're cystic and solid with septations. There's also ascites present. So you're now saying the patient has bilateral ovarian masses. What are we dealing with? Well, you could say ovarian cancer, but why would you get bilateral ovarian masses? This is not the appearance of tubal ovarian abscesses, which can be bilateral. It's not the appearance of hyperstimulation. What are we dealing with? That's a great question. If you look a little bit further on the cinematic rendered views, beautiful visualization of these large ovaries with the septations and nodularity, most consistent with tumor. So now you got to think. And if you look back a little bit, it's a little tricky, but there is some thickening of the antrum. When you see bilateral ovarian masses, you got to think malignancy, but you got to think mets to the ovary. Gastric is a really good one. Colon is a good one. Occasionally we've seen pancreas, we've seen breast. Classically, we talk about Krugenberg tumors, large bilateral ovarian masses. And so when I ask you the diagnosis here, you can see the stomach. There's infiltration of the antrum present. And this was a patient with gastric adenocarcinoma, metastatic to the ovaries and fallopian tubes. This was Krugenberg tumors, a really impressive example of that diagnosis. Again, I do like the cinematic, the way it shows you the texture of the patient's masses. Okay, let's go to the next case. 35-year-old female with palpitations, high blood pressure. What's going on? Well, when I give you a history of high blood pressure, you got to say pheochromocytoma without looking. And you do have a large right adrenal mass, and a pheochromocytoma is a possibility. Pheo is usually a very vascular. This is excretory phase imaging. Maybe it washed down quickly, but in the early phase imaging, you can see the large mass pushing down the right kidney. It's not very vascular. Now, Pheos sometimes are not very vascular, so it's a possibility. But the fact is, you would then look at the metanephrines, and I'll tell you the metanephrines were normal. So then you got to say, what else could it be? Large adrenal mass, you better think about adrenal cortical carcinoma. We think about Cushing's as the most common clinical presentation with syndromic presentation. Hypertension is another possibility. And this was a patient, when you think about it, had a large primary adrenal cortical carcinoma. Now, what else could it be? We said Pheo, a typical adenoma, doesn't look like myelolipoma. I guess you can say metastatic disease in the right history. But ACC, the more I look at cases, the more I realize the histories are so varied and the imaging is indeed so varied as well. So this was just a great case of a ACC. Okay, next case, FUO. What I'm showing you here is a large spleen with a cystic and solid lesion. When you see a splenic lesion and you see FUO, without thinking much, you say abscess. And that's a possibility, and indeed it's a possibility here. But you also got to think of what else presents with fever. Tumor. Maybe it's lymphoma. Lymphoma can present identical to an abscess, right? So a splenic infarct is another possibility. IV drug abuse, endocarditis. So cystic splenic lesions, particularly somewhat wedge-shaped, infarct, abscess, tumor. There's more of a solid component more medially. And one of the persons mentioned that when they discussed this case, and it made them think it was more likely tumor. Patient also has left parietic nodes, and yes, you can get nodes with endocarditis or a systemic process, But when I see nodes, particularly if they get bulky, it makes me think of malignancy, pushes me to lymphoma. Splenic abscess, you can get some local nodes, but that's fairly uncommon. So now you say, I have a splenic lesion, I have adenopathy, which is shown nicely on the cinematic as well, and a patient with a fever. Again, you want to make certain the patient doesn't have an abscess, but you always have to think about lymphoma. And in this case, the diagnosis was indeed a diffuse large B-cell lymphoma. It can be very tricky history-wise and also imaging-wise. Most of the cases I've seen with B-cell lymphoma, they have substantial adenopathy, so usually the diagnosis might be a bit easier than this case. Okay, abdominal pain. What do I see? I see intrahepatic duct dilatation and an infiltrating tumor in the hilum of the liver. This is not the appearance of hepatoma. It's a solid infiltrating tumor causing duct dilatation. When you see something causing duct dilatation, you always say cholangio. Cholangio can be denser as you go to late phase imaging. Cholangiocarcinoma is one of the things that we do delayed phase imaging on because of that, because of its fibrous tissue. This does not have the appearance of hepatoma, does not have the appearance of pancreatic cancer or biliary cancer. What else could you be thinking about? Hepatoma, again, not so homogeneous and not so infiltrating. Hepatoma typically doesn't cause duct dilatation. If you go to the next image, you can see how nicely the patient's hepatic artery is infiltrated. We think of what things infiltrate, and it always brings up infiltration of vessels, renals, the celiac, splenic, mesenteric. You got to be thinking about lymphoma. Lymphoma can infiltrate the hilum of the liver. Lymphoma causes vessel encasement. Cholangio more likely causes vessel narrowing. Interestingly, lymphoma is typically not associated with dilated ducts. And if I look at this case quickly, I'm going with cholangio all the way. But then the higher density, the infiltration, lymphoma should go near the top of your list. And at the end of the day, this ended up being B-cell lymphoma. A really terrific case. Okay, what about this case? I want to throw in another liver case. Vascular lesion homogeneous, central scar. Vascularity as bright as the IVC, not as bright as the aorta. So things you think about: FNH, hepatic adenoma, hepatoma, hemangioma. I mean, I'm just throwing all the things in there. Not hemangioma, doesn't have the puddling. The homogeneous enhancement can be seen with FNH or hepatic adenoma, more common with FNH. Central scar. Central scar, sorry about that, is more common with FNH, but can be seen in cholangios and hepatomas. But then when you go to the later phase, you see the lesion becomes infiltrating. It's essentially isodense central scar. You can still visualize the lesion. There's no cirrhosis. This is the typical appearance of a FNH, bright as the IVC, typically homogeneous, central scar, feeding vessel, and becomes near isodense fairly quickly. Hemangiomas can become isodense with central scars, but again, it's the appearance and it's the washout that makes your life easy, allowing you to make the correct diagnosis. Okay, what about this case? Incidental finding of what looks like a 2-centimeter anterior mediastinal nodule. This could be a node. It could be a thymoma. Castleman's disease, that'd be really crazy. Mets, I guess, one node, I don't know. What else could you think about? Again, lymphoma, it's not very much disease there. Metastatic something or other, not much disease. Thyroid, thymoma, it could be a small thymoma. But the other thing, although not a great location, but not a bad location, anterior mediastinum like this is an ectopic parathyroid adenoma. Yes, they're usually in the neck, usually at the base of the thyroid gland, but they can be in the anterior mediastinum, anywhere from the hilum of the lungs upward, can be well defined, typically vascular. Beautiful example here, beautifully shown in the sagittal view, and really, really nicely shown on the cinematic renderings. So this was an ectopic parathyroid adenoma. What a great diagnosis. Another patient, short of breath. Patchy infiltrates with some nodularity. You got to think infection. Again, could this be a tumor, particularly with that adenopathy present? I couldn't say no. You look at soft tissues, lots of nodes, pretracheal, AP window, anterior mediastinum, subcarinal. Lots of nodes. Maybe I'm dealing with a lung cancer, maybe an alveolar cell, maybe metastatic disease to the lung and mediastinum. When you look a little bit closer at the lungs, again, the mass could be a cancer. I can't say it's not, but there are other areas like right lower lung of nodules present, maybe multifocal metastatic disease. But this type of nodule is not very dense, adenopathy, younger patient. You also need to consider infection. There are great mimickers around, and this is one of the great mimickers, sarcoidosis. Now you can think about TB in this case. TB gives nodes, gives masses. Sarcoid, often along the interstitium. If you looked really hard, there was some interstitial involvement and small nodules also seen. This was sarcoidosis, a really good case. Okay, a patient with chest pain. Looks like mediastinal widening, maybe at this section. So you give IV contrast, and you see something infiltrating the aorta and branch vessels. And you say, could this be intramural hematoma? But that's usually eccentric. It doesn't scroll up into the arch vessels, particularly here the subclavian, but also the left carotid and right innominate. So what are we dealing with? You could say infiltration, vasculitis, tumor infiltration like lymphoma, but then you get a little bit weird. When you look at the sagittal view and you say, okay, really bulky, I got to be thinking about malignancy, but look at the encasement around the celiac and SMA. What's going on there? When I get the images at that level, you see infiltration of the peri and pararenal space, and yes, this could be extramedullary hematopoiesis, and yes, this could be a lymphoma, but this was Erdheim-Chester disease, classic infiltration around great vessels off the arch, classic infiltration of the kidneys and the aorta, and Erdheim-Chester is a very unusual disease, tough diagnosis if you've seen it before, perirenal fat effaced. I mean, the kidneys alone in this case could look like extramedullary hematopoiesis or lymphoma. Usually it's bilateral and symmetric, as was the case here. And also you can have involvement anywhere from the aorta, like in this case, the great vessels, through the iliac vessels. Often a difficult, delayed diagnosis on PET. The areas are hot. Again, confusion typically reigns in this case, but it's an important diagnosis. Okay, another case, shortness of breath. Patchy ground glass infiltrates both lungs, right greater than left. Airspace filling. You can think about vasculitis, hypersensitivity, pneumonitis, but you got to think about infection. PCP in the right population, CMV perhaps. You can see this again here on the coronal views. You're dealing with extensive infiltrates, more likely than hemorrhage. The patient had no symptoms and no hemoptysis. So what are you dealing with here? Patchy ground glass infiltrates, alveolar filling, parabronchial thickening, multiple lung involvement, multiple lobar involvement, infection, and this was TB. We always forget about TB, and it's a really good possibility. Okay, we're nearing the end. This patient had endoscopy with biopsy and a drop in hemoglobin. You look at the stomach, high density fluid in the stomach, active bleeding in the stomach present, which you can see very nicely here, really prominent vessels. This is impressive active bleeding in the stomach. Rare to see that from endoscopy, even with biopsy, but you can see it at times. And the diagnosis here was bleeding from gastric perforators following endoscopy with biopsy, and it is one of the complications. We talk about GI bleeding. CT is very good, both lower and upper GI bleeding. Really nice example, particularly useful when you don't want to be doing endoscopy in a patient like this one. So those are 10 cases. I love those cases. Those were great cases. And you know what? That's it. That's 10. Got no more. Gotta run. Wish everybody a happy holiday season. Have a great day, everybody.